Hello, friends. Greetings from India. So today we have a web meet on linear EBUS and update. We all know that the field of interventional pulmonology is expanding on day-to-day basis, and we see all new developments coming in each of the modalities that we perform in the interventional pulmonology. So with this in mind, we thought that we'll have an update on the endobronchial ultrasound procedures. So today we have with us three eminent international faculties of repute. We have Professor Kyle from US, Dr. Rakesh Panchal, a dear friend from UK, and Dr. Miguel from Spain to speak on various aspects of endobronchial ultrasound. We hope that this web meet will help you to gain more insights on the advancements in the field of endobronchial ultrasound and will help in your day-to-day clinical practice. So without wasting much of the time, I would like to introduce our first speaker. Our first speaker is Dr. Rakesh Panchal from UK, and he'll be speaking to us about EBUS, newer scopes and needles and update. Over to you, Dr. Rakesh Panchal, for your talk on EBUS, newer scopes and needles.
So good afternoon from Leicester in the UK. My name's Rakesh Panchal. I'm a respiratory consultant and interventional pulmonologist at the University Hospitals of Leicester here in the UK. I'd like to thank Dr. Viswesvaran from Yashoda Hospitals for this invitation for this webinar where I'm going to talk a little bit about scopes and needles. It's always great to work with the Yashoda group. These are my disclosures. So I work in Leicester, which is in the centre of England. We have a population of just under over 300,000. We're about 40 minutes from Birmingham, 2 hours from London. And University Hospitals of Leicester is has 3 hospitals, and I work at Glenfield Hospital, which is here in the bottom right, and we're affiliated to the University of Leicester here on the left. So in the next 15 to 20 minutes, I'm going to talk to you a little bit about slim EBUS scopes and the different biopsy methods that we have at our disposal. So the FNA, FNB needles, forceps biopsies, and cryobiopsy, which you'll have heard of more from my colleague, Dr. Miguel. So I'm sure you'd all agree that EBUS has been the greatest innovation in pulmonary endoscopy that we've had since the advent of, or the development of the flexible bronchoscopes in the 1960s. So Becker in 96 sort of came up with the radial probe EBUS, and the Yasufuku from Canada then evaluated the first convex probe EBUSs in around 2003. And then Wang Bo from Korea introduced us to the idea of putting the EBUS scope into the esophagus. And obviously over the last few years, we've got a number of different modalities for biopsy. So we have the ProCore FNB needles with a window to capturing more tissue. And then obviously in around 2020, 2021, Dr. Harry Kishan from the Yashoda group came around with the idea of cryo EBUS, which is very popular, and you've heard more about that from Dr. Miguel from Spain. So I'm going to talk a little bit about convex probe or linear probe EBUS. So we've got 3 main companies out there. We've got the Olympus scope here in picture A and D, which has a 6.9mm outer diameter. That's the traditional conventional scope we've got with a working channel of about 2.2. And as you can see, it has a 30-degree forward oblique view with the sheath coming out at around 2 or 3 o'clock when we're deploying the needle. The Pentax scope is smaller, has a smaller distal outer diameter of 6.3 with a 45-degree viewing, which is just above the transducer. And then the Fuji scope has probably a 10-degree forward oblique view, which is more similar or akin to the flexible bronchoscopes we're used to looking at. And it has a working channel of about 2mm as well. However, Olympus have come out in the last few years with a new slimmer EBUS scope. So in this top left picture here on the right, we've got the 6.9mm traditional outer diameter of the scopes we're used to using. And now the new thinner scope is 6.6mm. Not only does it have a more compact distal tip, the working channel is the same, but it's slimmer. And it has an advanced endoscopic view. So the traditional view, as I said, has about a 30 to 35-degree oblique forward view, whereas the new thinner scope has a 20-degree oblique view. Now, the traditional scope, the larger EBUS scope, probably had our practice isolated to the mediastinum, whereas this thinner scope allows us to go more into the periphery, identify more lymph node groups, and go into the periphery of the lung and biopsy lung masses as well. Another advantage is the angulation of the scope. So you can see here it's got a much more degree of angulation than the previous EBUS scope. Similarly, it has a steeper penetration angle, and this is much more advantageous in the paratracheal nodes, for example, the 4L and the 4R regions. So I've just got a video here comparing the two scopes. So this is the conventional U260F EBUS scope, and you can see it's still got a degree of flex. Okay. However, the new UC290F, so this is the thin Olympus EBUS scope, has got a much more larger degree of angulation, which I explained to you, gives you greater maneuverability deeper in the lung, and particularly in those trickier sort of paratracheal 4R, 4L regions. This is from an article from Fujino when they evaluated the new thinner EBUS scope. So the star at the top is the angulation of the thinner scope compared to the standard scope. And on the right, you've got the needle deployed. So you can see even with the needle in situ, there is still the degree of angulation is maintained. Again, in terms of the view, here in the top, you can see using the traditional 6.9 outer diameter EBUS scope with a 35-degree viewing angle, you used to have sort of a more oblique view of the tracheal bifurcation, and it was trickier to sometimes get into the right upper lobe. With the newer thinner scope with a 20-degree angle, you can see that you can see the carina directly in front of you at the tracheal bifurcation, and because of the smaller distal tip, it's slightly easier to get into difficult areas such as the right upper lobe, for example. So UK Anima did this nice systematic review and meta-analysis of the utility of EBUS to biopsy not just nodes, but actually centrally located tumors. So if the tumor is in contact within the airway wall and it's fairly central, then we can biopsy it using EBUS. And I'm sure a lot of us do this. And we know that EBUS has a sensitivity around 91% from this meta-analysis for biopsy of centrally located tumors. In this article a couple of years ago by Yasufuka's group again, and I want you to focus just here, they were comparing thin so traditional bronchoscopes and thinner bronchoscopes, and again, traditional EBUS scopes with the thinner EBUS scope. So this the TCP here is the thin convex probe EBUS in the middle, and you can see the angulation is much greater. And if I ask you to focus here, they did this study in pig lungs and ex vivo human lungs. And you can see when you put the conventional EBUS scope in and flex here onto the left, you've got a reasonable degree of angulation, but you can only go sort of probably into the less than proximal third of the main bronchus and not much further. Whereas here with the thin slimmer EBUS scope, you've got much more angulation. You can go into much more depth into the lung, not only to identify lymph nodes, but potentially identify pulmonary masses as well. And that degree of angulation is maintained, as you can see here, without the needle and with the needle here in the right upper lobe and here in the left upper lobe as well. And in this picture here, the orange area refers to the central 1/3 of the lung, and then the green areas refer to the middle 1/3, and the blue is the outer 1/3. And as you can see, with the thinner EBUS scope, we're not able to, with the conventional probe EBUS, we're probably able to reach this orange area. With the thinner, slimmer EBUS scope, we can go into these green and potentially these blue, more peripheral and deeper parts of the lung. So what are the advantages of the slim EBUS scope? Well, we can identify nodules in the middle third of the lung. It's easier to now go into the depths of the lower lobes. Traditionally, the upper lobes, which were difficult, you can get into them. Middle lobe and lingular is absolutely fine. And I know we're, in terms of biopsying peripheral lung nodules and lung masses, navigation bronchoscopy is popular now. But if you can get in with the slimmer EBUS scope, then it gives you an alternative to navigation bronchoscopy, and it's faster with real-time imaging, with a technique which we're all accustomed to using. And obviously navigation bronchoscopy is still not widely available. So the thinner EBUS scope gives us a number of advantages. Coupled with this, Olympus has brought out the new EU ME3 processor, which was released in 2023. This has higher resolution, better contrast, deeper penetration and depth of tissues, and improve elastography. I'm afraid these videos don't work, but you can see here in the classical B mode ultrasound, the old EBUS processors, the EUME2 versus the EUME3, you get much better resolution and contrast of the anatomy. And obviously with elastography, which gives you an idea of the stiffness of the tissue, and as you know, blue areas may look more malignant. The elastography gives you much better visualization of abnormal areas of the lymph nodes to target for biopsy. So moving on from sort of EBUS scopes and thinner scopes to biopsy methods, we now have a whole host of biopsy methods in our armory. So we've got the traditional FNA needles, and they're available from 19 to 25 gauge, produced by a number of different companies. We now have this new FNB, fine needle biopsy, or Francine needle, or crown tip for biopsy, and the Procore, which has a window in it. Intranodal forceps biopsy, so there's a variety of different biopsy needles which can go down. The working channels are EBUS scopes, and Boston Scientific have a specific core DX biopsy forcep, and obviously the ERBI 1.1 millimeter disposable cryoprobes for cryo-EBUS, which you'll have heard about more from Miguel. So the needles have been adapted largely from the US literature, excuse me. And we're now in the era of next generation sequencing, where tissue is the issue. It's not about just getting a diagnosis, but in lung cancer, we need sufficient tissue to do molecular analysis, next generation sequencing to further the patient's management. But when you review all these needles and biopsy methods in the literature, there's conflicting data, pro and against different needle types, and therefore direct comparison can be difficult because of the scope someone may have used, the procedure technique, was it conscious sedation or general anesthesia? Was it a single or dual operator? How many times was the needle passed? Was it 4, 5, 6 times? Did people have access to rows? So they did a couple of biopsies, got a satisfactory sample and didn't do any more needle passes. And what was their definition of sample adequacy? That depends on, obviously, on different pathologists. So comparison of the studies is difficult. So if we talk about the FNA needles, we've got Olympus's needles, which go from 19 to 25, the Cook Echo Tip, Mediglobe Sonotip, Boston produced the Expect, Broncos is bringing out a new one, and Microtech also have one, which is been adapted from the EUS data. So in this comparison of 21 and 22 gauge needles, they looked at a number of studies, and they found out that overall the sensitivity and the diagnostic yield was not really different whether you used a 21 or 22 gauge needle. You will be aware that Olympus brought out a 19 gauge needle, which was thought to be better for things like sarcoid perhaps, or lymphoma. You get a bigger piece of tissue. But again, in head-to-head comparisons of the 19 gauge needle with 22 gauge needles, in some studies, there's not really been much difference in diagnostic yield. The 19 gauge needle obviously has some challenges. It is a bigger needle, and you can see here, when you deploy the 19 gauge needle, it can be sometimes stiffer because it's bigger, and it can be stiffer to go through a cartilaginous ring, and it can be particularly tricky in the paratracheal areas where there's more of a bend. And then you can see here, and compared to a 21 gauge needle, the trajectory of the needle entering the node is very different. And some of you who've used the 19 gauge needles may have realized that sometimes maybe it may fracture, but you will get this bowing effect as well, especially when it's down the scope and you're flexing into the paratracheal area. So it gives you a bigger piece of tissue, but there are pros and cons of using it. And then in JOBIT, the Journal of Bronchology Interventional Pulmonology, there's lots of different studies comparing 21 and 22, 21, 25, 19, 21. And overall, most of them claim that the adequacy of the sample and the diagnostic yield, depending on whichever FNA needle you use, is very similar. So let's move on to the FNB. So this is the Francine needle, or the crown tip. So Mediglobe produced the top gain needle. Boston produced the Acquire needle, and Microtech, I understand, are bringing out an FNB needle as well, which they've used in the EUS literature. And obviously, Cook is the only difference, where Cook have actually got this cutting window, So instead of, as well as the bevel, they've got this window which captures a bit of tissue, and you're getting a more core sample. So what is the difference between the FNA and the FNB? Well, the FNA has a bevel on it, and when it enters the node, you're getting sort of a piece of tissue which may be suitable for cytological analysis. However, the FNA's crown tip, you're getting a core piece of tissue, like in a trephine fashion, which would be better for histological analysis. Now, when you look at the worms that you get in your formalin pot, when you look at them macroscopically for the FNA, FNB specimen, there is no real difference macroscopically. However, the pathologist sometimes prefers the FNB specimen, and I'll talk about that shortly. So UK Anima from Holland did this randomized controlled trial of comparing the Boston Scientific 22 gauge FNB and the 22 gauge TBNA needle. And they found out in the diagnosis and staging of lung cancer, there was no difference in the sensitivity between the two needles, and that perhaps there's a slightly more bleeding risk with the FNB needle. However, Osama Tawfiq from the US compared the FNB and FNA needles as well. They did 6 passes of the Olympus FNA needle and 4 passes with the Boston Scientific FNB needle. And yes, they found out that in malignancy, there was no difference in the diagnostic yield, but there was definitely a difference between the two needles in benign disease. Okay, so for example, sarcoidosis or TB. So if you're looking at malignancy, I think it doesn't really matter if you use an FNA or FNB needle, you'll get an answer. However, in benign disease, the FNB might be more preferable. Similarly, if you're looking at tissue and you're wanting tissue for next generation sequencing, the FNB needle in this study was able to get a better sample for molecular analysis, where the tumor cellularity was much better. And you were able to do that with fewer passes, 4 passes versus 6 passes. So perhaps there is some advantage using the FNB needle in certain instances. We did a head-to-head comparison of the FNA and FNB needles ourselves in our institution and presented this at the Winter British Thoracic Society meeting in December 23. And overall, we found out the diagnostic yield, the FNB, was actually better than the FNA. And when we asked our pathologists, which we blinded our pathologist, so the pathologist didn't know whether she was looking at an FNA or an FNB specimen. And she found that the FNB specimen was of a better quality with more preserved tissue architecture, and he felt that it was a sample which was more adequate or suitable for next generation sequencing. So when you do the FNB needle, you can see the crown tip here. It's no different to using an FNB needle. In terms of penetrating the tissue wall, there's no difference. It's not more stiffer. You don't really get much more bleeding. I would always encourage you to do a Doppler. Put the Doppler mode on before you deploy any needle, just so that you're not biopsying from a blood vessel or a very vascular area. But you can see that obviously you will see the crown tip here, and there's no real difference in what you observe when you're doing the passes or the biopsy. So moving on to the Procore. So the Cook Procore is the only novel needle in that it has a bevel, but as you know, it has this window or cutting window. And again, this study looked at the Procore Cook needle versus the standard Cook needle and found out that there really was no difference in cancer diagnostic yield between the two needles. So let's move on to intranodal forceps biopsies. So the third technique, forceps biopsies, was sort of thought, well, you know, we've all been doing endobronchial biopsies for tumors for years. Surely if we were able to get a forceps biopsy into the node, we'll get a bigger chunk of tissue. And people use different diameter forceps, so 1 millimeter mini forceps, 1 millimeter forceps with a spike on it. And Boston obviously brought out their own Core DX mini biopsy forceps with a 4.3 millimeter opening, so it's quite wide. And the principle here is you create a tract using a FNA or an FNB needle, okay? You then memorize some reference points on your ultrasound so that you know the image that you've got, and then you deploy the biopsy forceps through the same hole where you put a needle. So you have to use a needle to get through first, and then you open the jaw, take a biopsy, a chunk, and then you close the forceps and take the tissue out. So Amit Damajia's group from Delhi presented their first case series of using a 19-gauge needle to create the tract and putting a biopsy forceps in. And then Sami Lacar's group from France, again, also looked at intranodal forceps biopsies with a 19-gauge needle to make your initial puncture. But I'm going to focus on Abhinav Agarwal and Udit Chadha's meta-analysis from New York, published a couple of years ago. So here they looked at all the studies which have used TBNA, which we know, and TBNA plus intranodal forceps biopsies. And obviously a technique which uses TBNA plus intranodal forceps biopsies is favored for getting a better diagnostic yield. But obviously, I mean, some of these studies, there was a risk of pneumomediastinum and a bit more bleeding. But all these studies obviously had limitations. There was a selection and operator bias. Obviously, forceps biopsy was only used in patients where the FNA needle with a rose was negative. Where people use forceps biopsies, they'd actually taken fewer TBNA passes when actually the TBNA may have given the answer. And there's no information in any of these studies on the tissue volume for molecular analysis or the diagnostic yield by different cancer types. And people had used different needle types and different forceps. So it's difficult to gauge sort of concrete answers, but certainly a technique where you use TBNA and forceps biopsies and the correct patient might be preferred. So we have all these modalities in our EBUS armory now. FNA, different gauges, not much difference, but 19 gauge, if available, you may wish to use in certain instances. FNB, forceps, and cryo. So I think my take-home messages from this are the slim EBUS scope gives us distinct advantages, better visualization, more angulation. We can go deeper into the lung and not just concentrate on the mediastinum and biopsy lung masses, perhaps, which are deeper in the lung. TBNA needles will suffice in the majority of cases, that there is no real difference between which gauge FNA needle you use, but you need to tailor your approach to different subpopulations. So if you just want a cancer diagnosis, an FNA needle will suffice. But if you want to look at lymphoma or sarcoidosis, or you need more tissue, or your FNA is not giving you the answers, then you probably need to look at different modalities. That might be forceps biopsies or cryo-EBUS. And this can be done under conscious sedation. But ultimately, your practice is going to depend on the resources and the access you have, the cost and the reimbursement. Remember, we want to maximize our diagnostic yield in the fewest amount of procedures, and we need to do what's best for our patients. So I'll leave it there. That was a sort of whistle-stop tour of thin EBUS scopes and different EBUS biopsy methods. It's great working with the Yashoda group, as always, and I shall leave you there. Thank you.
Thank you, Dr. Rakesh Panchal, for excellent insights on the newer advancements in the scopes and needles in linear EBUS. And to follow this talk, we have a talk by Dr. Miguel from Spain, who has been doing a lot of procedures on EBUS intranodal cryobiopsy and has got a lot of publications to his credit. So today he will be speaking to us about EBUS intranodal cryobiopsy and how he does it. And we all know that the EBUS intranodal cryobiopsy has increased the yield of EBUS linear EBUS samples in a significant way. And let's learn from him how he does it and what are the evidences that backs his experience. Over to you, Dr. Miguel.
Good morning. Thank you very much, my dear friend Viswesvaran, for the invitation. It's a pleasure to be here and to share our experience in mediastinal cryobiopsy. So let's begin right away. I love music. It's one of my passions. I try to bring music to everything I do at work. So imagine the first picture in the upper left side was me in 2014. I was a resident and I was playing in a concert in a congress in Madrid, while a lot of colleagues were doing lectures. So I always bring music to my work. So why do I start with this? Well, let me keep going. Here you have these 6 wonderful songs. 6 songs that were in the chartboard top. I mean, #1, and still for me, they are. I love this music. So what do they have in common? Let me tell you that you can play all these 6 songs, all these 6 hits, just with 3 chords, guitar chords, in different positions, but the same guitar chords. And why do I say this? Because I'm going to try to explain to you, I'm going to try to share the way we perform mediastinal cryobiopsy, just using 3 simple steps, 3 simple guitar chords that you will be able to perform a mediastinal cryobiopsy in a safe, in a fast, and in an effective way. And simple does not mean easy. We started this in January 2022. I will tell you the story, and it has changed a lot, the technique, since we are now. So we have made the technique more simple than it was at the beginning. So why? Why did we start performing cryo-EBUS? In 2020, the hematologist called our unit to perform a conventional EBUS TBNA on Daniel. Daniel was is still a 19-year-old kid that had suspicion of lymphoma. So we performed the EBUS TBNA in station 7 and 11 RS, and it was negative for malignancy in the histological analysis, but in the flow cytometry it was suspicion of lymphoma. But the subtype was not, we were not able to identify which lymphoma it was. So Daniel went to a mediastinoscopy and they got the diagnosis. It was a non-Hodgkin type B lymphoma, but the mediastinoscopy got complicated and he had a major hemorrhage. He spent 45 days in the ICU until he was discharged and then treated. So in 2022, in January, again, the hematologist called again our unit to perform an EBUS TBNA on Daniel again, because of suspicion of relapse of his lymphoma. So that's when, for me, everything started. We have been studied before. I will talk about this paper of 2021 that the Chinese group performed a mediastinal cryobiopsy, and we decided to do it in a different way. So we performed the mediastinal cryobiopsy, we got the diagnosis, it was non-Hodgkin type B lymphoma again. And that for me is when everything really started in January of 2022. I have to, of course, bring up this paper from 2021, the Chinese group, where they performed mediastinal cryobiopsy for the first time using the high frequency needle knife. They performed it in 197 patients, and they observed they had 2 cases of pneumothorax and 1 case of pneumomediastinum. It's important to mention that in 26 cases, 8%, the TBNA was not diagnostic. So the TMC did establish the diagnosis in 6 non-small cell lung cancer, 6 lymphomas, 1 seminoma, 8 tuberculosis, and 5 sarcoidosis. But at the end, what we really loved about this paper is that they ended saying that it was safe, even though they were using a new technique in the mediastinum as it is the needle knife. Even though they had 2 cases of pneumothorax and 1 case of pneumomediastinum, that with the TBNA, it's really not so frequent. So how do we do the technique? As I said, this started in January 2022 with one of my best friends and colleague, Dr. Javier Perez Pallares, here in Spain, and we did it with, and we do it with a 22G needle. This needle is 0.7 millimeters in diameter, and we do it in our IP unit with moderate sedation, with midazolam and fentanyl, the same way we do the conventional EBUS TBNA. We perform the mediastinal cryobiopsy. We started using the 22G needle and for the first 50 cases, and now we use a 22G needle, but the sonotip top gain, which has a crown cut tip at the end, and I will show you why I really like a lot this needle. So we use the Every Cryo 2 system, and of course, the 1.1 CryoPro. So this is the needle we use. We started with a standard needle tip, and then we changed to this one because it maintains the external diameter at all times. And you can make a tunnel, break the mucosa, the submucosa, the capsule of the lymph node, and maintain that external diameter. So it's going to be easier to introduce the 1.1 CryoPro than when you use a standard needle tip. So you're going to shorten the time of the procedure. So our method consists in 3 steps. The planning, you always need to plan what you're going to do. This is very important. Of course, the puncture, and in the same time, when we're doing the puncture, we're making the tunnel to get then the cryobiopsies. So step one, the first core, the planning. You have to choose the best place and you have to choose it wisely. If I'm going to play Hotel California, I am going to take probably my electroacoustic guitar. If I'm going to play, I don't know, November Rain, I'm going to take a solo, something, I'm going to take the electric guitar. So I know what I'm going to do in each time. So that's, the planning is very, very important, because when you make the first puncture, this will guide the rest of the process. Here we have the same patient and different cuts in the CT. As you can see here in this image, the 4R lymph node is quite far from the right paratracheal here. So you need to see this and try to obtain the image which the lymph node is almost touching or is closer to the tracheal or bronchial wall. So here I will say, okay, this is going to be very easy cryo EBUS here, because even 4R station and 4L are almost touching. So you have to plan everything. It's true that if you make the puncture, the cryoprobe will follow. Doesn't matter the station, but you need to know what you are really facing in each procedure. So this is what we really want. We want a lymph node with a very thin capsule, with a very thin mucosa. Always put the Doppler, that's very important, and always avoid the cartilage, okay? Because if you do not choose the best place, as this, for example, this is the distance from the needle to the capsule of the lymph node. It's almost 1 centimeter. This is going to be even difficult to make the puncture. Imagine it then to make the tunnel and then to introduce a 1.1 cryo. So you have to move the lymph node just a bit and try to go to the periphery of the lymph node to do it more easily. And of course, always the Doppler mode. So step 2, the puncture and the tunneling in the same process. Okay, step 2, you're going to make the puncture and the tunnel. We recommend 2 operators. This doesn't have to be 2 bronchoscopies. I do it with my residents. I do it with my nurse. If I have my colleague over here, I will do it with him, of course. But I really believe this is a 2-operator technique, because one is holding the EBUS scope very firmly, just moving millimeter movements in the same angle and plane. And the other one is concentrating in making the puncture, in making the tunnelization, and then introducing the 1.1 cryoprobe. So you need, like here, put like we are dancing tango. You need to dance very well with your couple when you're performing this technique, because the first puncture will guide the rest of the process. So suction versus no suction when you're making the normal TBNA. That depends. I put the Doppler mode. If I see a lot of vascularity, I am not going to put suction on it. And if it's okay, I will put it. I will make 6, 8, 10 passes, normal passes as you usually do in the conventional TBNA. And of course, I use the Doppler mode. So with this needle, you need to make a solid hit. Okay. So as you will see, it also has this blue sheet that I like a lot. It's not gray, so I can see it every time. So you'll see that my colleague makes a solid hit and I make a push. Boom, I make a push inside. That's the way I would puncture with this needle, because it has this crown tip needle and doesn't go in that easy as a conventional needle. So in the same procedure, the tunnelization, the next cord. So suction versus no suction in this part. We're making the passes, 6, 8, 10 passes, and then we have to concentrate in the proximal part of the lymph node, in the mucosa, the submucosa, the cartilage layer, and then the capsule. That's what we want to break, because if we do not break the mucosa really well, we are not going to be able to introduce the 1.1 cryoprobe, even though the capsule is already broken. So at that proximal part, I do not want to put suction, because I do not want to traumatize that part. And I'm going to shorten the length of the needle from distally to proximal, going to the capsule and in, to the mucosa and in, almost out of the lymph node and in, just to break that part. Let me show you here how we do it. So we are making here the normal TBNA, a conventional TBNA, passes 6, 8, 10, the passes you really do in a conventional time. So he's almost coming to the capsule of the lymph node. This is the capsule here of the lymph node. He's taking almost out the needle, as you can see. And then you will see he now is going to shorten the length of the needle, and he's concentrated on the proximal part. And now he doesn't feel any resistance, and he's going out and in, out and in. Here you can see this gray line. This is the broken capsule, okay? So you can see it very well, but the one he's holding, the EBUS, cannot move, okay? You need to be very, very firmly here. That's why we said it's two operator technique. So how does a broken lymph node capsule looks like? This is very important because at the beginning, this was not a echo-guided procedure. So now it's completely, we turn the endoscopic image away and we do not see nothing in the endoscopic image, only the ultrasound image. So in this image, would you say that the lymph node has a broken capsule over here? Let me tell you, this white line says to me no, but this capsule was broken. It's just that if you move the EBUS scope 1 millimeter to the left, you then will see the broken capsule. So here you have this continuous line, this gray part, this is a broken capsule, here as you can see. And here you will see also the needle trace from the needle that goes also with the broken capsule. So this is what you need to find when you are trying to take the cryobiopsies, okay? So step 3, the cryobiopsy, okay? The third court, the EBUS image, the needle trace, as I said, the one is holding the EBUS in the same place and same angle, always Doppler mode, the 1.1 cryoprobe, where to freeze, how many seconds, and how many samples. These important questions. Where to freeze? Okay, you can do it in the proximal part of the lymph node, in the medial part of the lymph node, in the distal part of the lymph node. It's okay. You can also perform fanning technique when you're performing cryo-EBUS, okay? It's okay, you can do it, okay? So you can go to the periphery, to the central part. That doesn't, it is not a handicap here. How many seconds? This is important. In 2021, and there are different papers that have had mediastinum pneumothorax, is because they freeze for more than 9-10 seconds, okay? And when you do that, this is what happens, okay? We are freezing here 3, 4, 5, 7 seconds, okay? And as you can see, the proximal part of the cryoprobe, it's freeze, okay? You do not only freeze the tip, you also freeze this part of the cryoprobe. So you need to be careful with this, because when you're going to take out a block, you will have, or you could have pleura here. So that's why a pneumothorax and pneumomediastinal. So here's what's happened when you freeze more than 7 seconds. As you can see, the cryoprobe continues to freeze over there. So what we do is we do not freeze more than 6 seconds, okay? 5, 4, 6 seconds, that's okay to get a good cryobiopsy. So now we are introducing the cryoprobe, as you can see here. We're looking for the broken capsule. He's very gently introducing it. I do not have endoscopic image at all. I am not looking for the puncture site. It's not necessary. And at the same angle, you will see that the cryoprobe goes in very gently. And as it is very hyperechogenic, because it is a metallic tip, so you will have control at every time. So always use the Doppler mode. Here you will see a vessel very close to the cryoprobe, but it's okay. I said, okay, I'm comfortable here, I'm okay. So now I'm going to hold the cryoprobe very firmly, but without breaking it and without bending it, just a bit, with my 5th and 4th fingers, okay? So I'm going to hold it very firmly. I am going to press the pedal for 4 or 5 seconds, and I am going to bring the EBUS scope as a block, and then I have my cryobiopsy there, okay, with no complications at all, in a very fast way. So you could do it searching for the puncture site, but this was at the beginning, as you can see. And where is the puncture site? Here, 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 here. I really don't know. The patient is coughing, is going, the EBUS scope is like retracting every time I introduce the 1.1 cryoprobe. So you could do this and you could have a 30% hit and miss. So when you do it, you go, yeah, perfect. Now I'm going to the 11RS station, and you are going to have difficulties and you're going to have problems for R station, for L. So this is a completely ultrasound guided procedure. You need to look for the broken capsule and the needle trace at the same angle, because if not, you are not going to be able to do it or reproduce it in 90-95% of the cases. So in which cases cryo-EBUS can be made in all stations, from easier to most difficult. 11L is very easy, 11RI, the 7, 11RS, 2R, 2L. I think the same as TBNA, 4R and 4L sometimes are the most difficult lymph nodes to puncture in TBNA, but it's the same with cryo. And when not to do it, same contraindications as EBUS TBNA, the same, okay? Just be careful with the grade 3 and the bronchial artery inflow sign when you put the Doppler mode, because those types of bleeding that you will have with a TBNA, you also would have it with your cryo. So that's what you need to look for and try to avoid it. But the contraindications are the same. The bronchial artery inflow sign, of course, be careful with this. Even when you see this, do not go there. Try to find another angle and avoid that. So when to do it? A lot of indications. Okay, there are not, if you're going to perform a TBNA, the indications are going to be the same with the cryo because technically you can do it. Okay, but this is what we believe. If I have a suspicion of lymphoma, both for de novo or for recurrence diagnosis, I am going to perform a mediastinal cryobiopsy. If I have a suspicion of benign granulomatous process like sarcoidosis or maybe infectious ganglion TB, or here in Asturias where I have a lot of silicotic patients, I have enlarged lymph nodes. And in my differential diagnosis, lymphoma comes into play. I will do a mediastinal cryobiopsy. Okay, that's what we are really doing here. If I have metastasis, suspicion of metastasis from other non-pulmonary tumor like seminoma, thymoma, thymic carcinoma, that are very difficult to obtain with the TBNA, and we know that the diagnostic yield is very low. And I need specific immunohistochemical and molecular studies. I will perform a cryo EBUS. If I perform an EBUS TBNA and it was not diagnostic because I had insufficient sample, I am not going to repeat an EBUS TBNA. I'm going to go for the cryo. If I have necrosis with my pathology in my room, and he says, "Hi, Miguel, I hear you see too much necrosis, too viable cells. This is probably an advanced stage lung cancer. I really need something else, to make the mutations, the determinations, and all that." So here I will give him a cryo, okay? In lung cancer, when PD-L1 comes into play, the cryo gives a better preserved architecture. We're making a study right now between PD-L1, TBNA, PD-L1 cryo, and there are very important issues over there. Okay, but I'm not going to tell the story. It will be published very soon. So also in restaging the mediastinum after induction chemo and or radiotherapy for locally advanced non-small cell lung cancer, I am also going to perform a mediastinal cryobiopsy. But you need to individualize each case, okay? Because the EBUS TBNA has a very, very high negative predictive value, and it's wonderful, okay? We are not doing cryo in all patients. We perform around 700 EBUS per year, and last year we performed 250 mediastinal cryobiopsy, and then the rest, 500, were conventional EBUS. So you have to individualize and select each case, okay? That's what we really think. So we published our first paper in 2022, how to do it, just the first 5 patients that we did, step by step. Then we published our experience in 50 cases, also explaining the technique, and just important here in the results. The diagnostic yield with the TBNA was 82%, with the cryo was 96%, but as I have a TBNA sample and the cryo sample, because that TBNA sample with the tunnel is a very good sample, I got a diagnostic yield of both techniques of 100%. So I didn't have to repeat any cases. But 9 patients of that series were non-diagnostic by EBUS TBNA. Only the cryo give the diagnosis. So I would have to repeat 9 patients in my series, okay? I had no pneumothorax, no pneumomediastinum, and the technique was safe. You also can perform mediastinal cryobiopsy through the esophagus, okay? We published here a case that is feasible. It's the same technique, breaking the mucosa to mucosa in the capsule. Only do it very fast because, as you know, the mucosa of the esophagus closes very fast. So have always the cryoprobe very close to you. When you break the capsule, take out the needle and rapidly introduce the 1.1 cryoprobe just to get it into the lymph node. We have performed 32 cases right now of mediastinal cryobiopsy transesophageal way with cryo with no complications with the needle. Okay, we do not use the needle knife. Just to say, and I don't want to go really deep over here, they have compared also the cryobiopsy and the forceps in the mediastinal lesions, and the cryo was superior. This happens also when you compare forceps with cryo in endobronchial lesions, or the forceps with cryo in peripheral nodules. The diagnostic yield is higher with the cryo. So I'm not going to go very deeply here. I do not perform forceps in the mediastinum. I prefer doing the cryobiopsy. So a lot of patients already in the literature, more than 600 patients, no major complication. This is a safe technique. We have performed over these 2.5 years, more than 400 patients with no complications. We have also had the chance to visit a lot of IP units outside Spain and in Spain. We have performed more than 100 patients over there with no complications at all. And here in Spain, more than 700 patients were performed last year. So I believe the learning curve could be like 30, 35 cases, do it very rapidly, 1 to 2 months, and also go to all stations. And we're doing this study, 1 shot, 1 puncture, 2 cryos. Let's see at the end how it goes. And just to end, my conclusions are, if you do conventional EBUS, you can perform a cryo EBUS. If you don't believe in what you do, don't do it. Okay, I believe that cryo EBUS is very useful, at least for me. The Sonotip top gain needle, this needle makes it a lot easier. And if your diagnostic yield for all mediastinal pathologies is above 96%, you don't need to perform this technique at all. You need to select and individualize each case. And always remember, keep it simple, but significant. So I want to thank, again, my dear friend for the invitation, and I hope to see you all very soon. So thank you very much, and always share, share, share. Thank you.
Thank you, Dr. Miguel, for an excellent talk on EBUS intranodal cryobiopsy, and you also shared on how you perform it in your day-to-day clinical practice. I think this will be really helpful for all the participants here who are practicing EBUS intranodal cryobiopsy. So to deliver our final talk, we have none other than Professor Kyle, very friendly and an enthusiastic interventional pulmonologist and a mentor, and he's based out at USA. So today he will be speaking about the utility of the linear endobronchial ultrasound beyond staging. Over to you, Professor Kyle, for your talk on EBUS beyond staging.
Thank you, everybody, for having me. I wish I could physically be there, but right now I'm recording this from the country of Barbados, which is unbelievably it's paradise. So I'm doing pretty well. But I do wish I could be there live and meet with you all. But in absence of that, what I've been asked to talk about today, and I'm really honored to be able to give this talk, is to talk about the linear EBUS scope, but to look at that in different ways, beyond what you and I normally do, of course, and this is the workhorse for staging of the mediastinum, obviously. But there's so many different ways we can think about using this scope in different clinical scenarios, and I've been asked to expand on that. My name is Kyle Hogarth. I work at the University of Chicago, and I run the bronchoscopy program there. Okay. So we're going to go through EBUS staging real briefly, like 1 slide. But then we'll go through talking about sampling of lung nodules and lung masses. And obviously, with the newest iteration of the EBUS scope that's smaller, we can get out further. And so instead of having to so-called navigate and or blindly puncture the wall, we can use some guidance. We'll talk about EBUS also for non-carcinomas, a slightly different challenge. Usually, obviously, we're sampling lymph nodes for the staging of a carcinoma, about when you start entering in lymphomas. We'll talk about non-cancers as well, sarcoids and infections. And then obviously you're looking at EBUS for even sampling other structures in the mediastinum, some interesting work. And then EBUS for PEs, I apologize that E didn't get capitalized, but for pulmonary embolisms. And then we'll just talk about some tools of the trade that add to what you and I can do. All right, so this is it on staging. This is our workhorse, but it is, staging is the 90% plus of why I use an EBUS scope. But there's also just a nice visual reminder of where the territories are for when we're sampling, as you're making your recording of, noting where you took a sample. And I like this nice piece of work. It's been around for a while from Murgu and Colt, but it's extremely useful to remind you your anatomic landmarks. And so you can always be 100% assured that you're sampling 4R versus 4L, for example, simply from the perspective of declaring where that lymph node is dictates that person's nodal stage, dictates then that person's outcome from, say, their lung carcinoma. So this is one of my favorite slides. Feel free to use it. And if you want it actually in a PowerPoint presentation, email me at the end and I will send it to you. This is also available Bronchoscopy International, which is the organization that Murdu and Colt had started years ago, and Dr. Colt still runs. All right, let's do an example of lung masses. Now, still, this might be an obvious example, but if you look, the big nasty mass, and the airway is actually going to go sliding right past it. So yes, this is kind of an over amplified example of what we're going to be able to do, because I think all of us would arguably feel very comfortable just doing a so-called blind TBNA at that junction, and for sure. I mean, but what I want you to do is envision this to be smaller. This was just a recent case example we had, and rather than go hunting for some micro nodule that we did it on, I just thought of, get the principles across. And so, imagine this is smaller, or imagine it's surrounded by, you can see obvious vasculature, large pulmonary emboli or pulmonary artery, et cetera, et cetera. And so, and on the, and here are the two more views of it, but on the scope view, and like I said, obviously in the lower lobe here, I think all of us would feel fairly comfortable just blindly stabbing that. But work with me and envision that this is smaller. Work with me and say, there's actually some large vessels around there, and this patient's got borderline platelets, et cetera. Regardless of the size of this and whether you could so-called do this blind, look at, of course, principally of being able to see an actual mass, see your needle going into the actual mass, and more importantly, then being able to, at the same case, go and prove that in this particular example, which was kind of surprising, that the 11L node, which is obviously not far from this area, was negative for carcinoma. So though this is a big cancer, and it was an adenocarcinoma of the lung, it had not yet had any regional spread. So there's an operative opportunity for cure here as well, too. So, this is an obvious example, but if the scope will fit, and obviously the newer EBUS scope is smaller, don't be afraid to get out further and make this nodule instead a 1 centimeter nodule, not right at the carida, but which part of the airway would you have stabbed at, and so forth. And again, we can all do this, and we all know that TBNA is a very safe and simple procedure. But why not add a higher level of precision and a higher level of safety? The mantra that I usually tell people is that getting lucky is not a plan, right? You can study the anatomy, but there's micro changes if this nodule is small enough that having EBUS would help. I mean, look, we all used to sample lymph nodes without EBUS, and you can do it. I mean, I learned from Dr. Mehta how to do that as well, but I've gotten a lot better at it using linear EBUS, if for no other reason I'm not as good as Dr. Mehta. So, the advent of this technology makes things a lot easier, and to think about, being able to use it out in the lung itself. Now, what about non-carcinomas? What about when we got, concern, should we as a group be sampling lymph nodes if there's a concern for lymphoma, for example? Because historically it wasn't the best with EBUS. The sensitivities range from 37 to 88%. A relapse was more sensitive than a de novo diagnosis, partly because I believe there was already this perception of what I was looking for. And for lymphoma, though, and interestingly then, just to kind of change this discussion a little bit, a small study evaluating patients with high pretest probability for lymphoma. So there again is the bias that you really thought of this. They're in a tertiary cancer center, so another bias. But then it said an overall sensitivity was 90% with a specificity of 100%. And now we still need, and there have been larger prospective studies that said the sensitivity and specificity is not as good as we'd like, 57 and 100% respectively. It is interesting, the specificity is quite good, and I think this is partly because you can do with EBUS samples, you can send it for flow cytometry, but you do really want the histology and the hematologic pathologists. Their challenges is separating out obviously normal from abnormal. When you're sampling a lymph node full of lymphoma, there is potentially still going to be some normal lymphocytes in there versus the cancer of the lymphocytes, and so it's where the challenge, I think, rests. But when you do look, I mean, there's a couple different studies that have explored this. The numbers are not where we'd like them to be. So it's something that we need to always, I think, upfront state that we can be involved. And I think on-site cytology can help in this situation dramatically, so you can ensure you're getting enough samples. I also think multiple samples matter here, and potentially even changing out needles if your needle starts to get a little bloody. Potentially bigger needles, and then potentially some tools I'm going to talk about at the end, either doing cryobiopsies of the lymph node or forceps biopsies of the lymph node. So, and that's, let me transition that into, EBUS TBNA, as we saw already, has its issues. But if you add EBUS TBNA plus EBUS intranodal forceps biopsy, that's the EBUS IFB, we obviously need more research. But when you look at what's been done, when Hearth reported the overall improvement in the diagnostic yield using the forceps biopsy, intranodal forceps biopsy, it went way up, obviously. And Christian reported that this also in the diagnosis of lymphoma, and it was 4 out of 4 with the forceps, 0 out of 4 doing the aspirin. That was with the use of flow cytometry. One was a Hodgkin's, where people always talk about wanting tissue. Now, all many forceps samples were adequate to guide management in all cases of lymphoma. So it does make an argument, and we'll look also at when we start talking about forceps later, of whether or not forceps through the EBUS scope also add things even in the carcinoma world that we're dealing with, typical staging of lung cancer, et cetera. But this might be, and we'll come back to this tool, but this might be a better add-on to what we're doing whenever we think lymphomas in the diagnosis. Now I want to transition and talk about sarcoid. Sarcoid is also a significant problem in the sense of EBUS TBNA. The yield is at 83%, and it remains lower than the diagnostic yield, obviously, that we're associated with for carcinomas. Part of it is that non-caseating epithelioid cell granulomas are difficult to identify from cytologic samples. And then using a nice presentation that Bobby Mahajan put on at ANOVA, they used EBUS intraforceps biopsy, and they got histologic samples with tissue architecture, and they were able to improve their diagnostic yield for things like sarcoidosis. And it has that sensitivity, nice specificity, and then again, in a high pretest probable population, your sensitivity goes up. We'd like it to be, and these are some older trials, but I believe, and this I think varies by region and also by patient population. My particular hospital has a significant rate of sarcoidosis. If we see, the micronodules in the lung, but big lymph nodes, we've taken to simply sampling the lymph nodes. We have on-site cytology; they will find us granulomas, rather than take the additional risk of transbronchial biopsies. And again, transbronchial biopsy is a safe procedure; we all do them. But there's, a known, obviously, rate of bleeding and pneumothorax, et cetera. Obviously, EBUS TBNA is infinitely safer, and so we've taken to doing that more. And I think as the data improves, we're further justified by that. Now, when you look at taking, an idea of doing EBUS versus conventional bronch, this was the granuloma randomized trial. And if you look right down at the conclusions, among patients with suspected stage 1 or 2 pulmonary sarcoid undergoing tissue confirmation, the use of EBUS nodal aspiration with bronch biopsy resulted in greater diagnostic yield. And so it wasn't just taking endobronchial biopsies and taking transbronchial biopsies, but when you sample the lymph nodes, you're adding to the entire picture. So if, for example, you're still not 100% confident in the EBUS sampling and/or your pathologists work with it, and you're going to do, transbronchial biopsies, there's micronodules, great, but add this to it. The diagnosis of sarcoid is always this diagnosis of exclusion anyway. So wanting to prove that you find these tight granulomas in multiple areas is never a bad thing. Now, I'm going to transition quick over to histoplasmosis. This is obviously not an infection that's endemic to India, but extremely endemic to a significant amount of the part of the United States. And this slide is from Sadia, so I'm giving full credit. But histoplasmosis, as you'll notice, has got a worldwide distribution. And I take it back. There are some descriptions in parts of India. I did say it was not native to India, and that was a lie. It's a significant amount of the United States, as you see here, as well as parts of South America and through the Horn of Africa and parts of Australia and Malaysia. And I highlight this because obviously, of course, we all practice in our countries, but we all practice around the world as well, and so it's worth knowing. It's usually it's birds, back guano, cave exploring, bird roots, chicken coops also is one of the places, but any soil exposure is ultimately where it comes down. And my always thing I say with patients, if you've dug in the dirt once, you've been exposed. And then obviously travelers into an area as well, or if there's a massive construction project going on in soil. There was a 30 years ago, south of Chicago, they were building this brand new factory, and they dug up so much dirt. There was all old farm soil. They had a massive outbreak of histoplasmosis. So anyway, the types of histo, this is just brief, but there's the acute, subacute, and chronic. But the challenge is to prove this and to separate it from looking at sarcoidosis. So I'm using histo as an example, but obviously infection sampling with EBUS is important. I've diagnosed a handful of times. Tuberculosis is not as common in Chicago as it is in other parts of the world, but we've had obviously tuberculous lymphadenitis and proved it that way with histoplasmosis, blastomycosis, coccidiomycosis. And it doesn't typically grow on culture. It's just the nature of this fungus. And histiocytes and granulomas is not enough typically, though obviously you can have a pretest probability. There's also antibody-based testing. But sometimes you can find the yeast on GMS stains. And so it is important to get enough sample. And if you find granulomas, you see any amount of necrosis, but they're not always necrotic. It is worth staining for these bugs, again, in an endemic area. So this was just to highlight, obviously, that we should be always thinking of EBUS as well in the setting of there's lymphadenopathy, and even if people are concerned and maybe something infectious, we should be involved. Now, let's transition over into other structures. So this was, there's 2 case reports from Martinez et al. Using EBUS-B. So this is the bronchoscope, but in the esophagus, something that we all can do. Guided FNA for diagnosing cardiac tumors. So you'll see, obviously, here's the scan showing there's a hematoma adjacent to the right atrium, and then this tumor in the left atrium adjacent to the esophagus, right? And EUS-B image right there, you can see this tumor inside the left atrium, and then the elastography pattern, obviously giving consistency with it, and then there's your needle into the tumor. And a high cellularity, and then fortunately this person proved a synovial sarcoma. Now, obviously this would be done in discussion with your cardiology folks as well as cardiac surgeons. I think the thought process here was, of course, this person potentially is going to need some form of a surgery, potentially a curative surgery, and so there may not be a reason to sample this pre-surgical intervention. But we can all envision scenarios where this person's not a surgical candidate, or there is not the expertise to go and remove an intracardiac tumor, but you want to be able to prove it and then treat it, et cetera. So one very interesting case report. And then here's another one. Again, a nice tumor inside the left atrium, adjacent again towards the esophagus. Right there, you can see it. And a bilateral pleural effusions, which were negative apparently when tapped. And there's again tumor inside the left near the entrance of the right atrium, and then cytologic sampling there again, showing a Burkitt's lymphoma. So kind of bringing around it in 2 ways: 1, diagnosis of lymphoma, but 2, thinking of EBUS in different creative ways. Now, clearly, these are rare. I mean, cardiac tumors, right? How many of them are we going to diagnose in our careers? But it's a reminder that, of course, if there is a pipe, whether it's a trachea or an esophagus, and there is a lesion nearby, we should be thinking about sampling it through EBUS. When I go back to my first examples of biopsying a lung mass, one of the first times we ever started doing lung nodules via EBUS were things in the right upper lobe that were apical medial and were essentially next to the trachea. They weren't obviously lymph nodes. You could see the lung nodule, but it was something we could either navigate all the way around and try to get to, or just stop mid-trachea, see it through the wall, stick the needle through. Now, yes, you're going transpleural, so you have some risk of a pneumothorax that's higher than you would for a navigation out there. But some of these lesions, if you can imagine, if they're right next to the trachea, it is definitely easier to just go straight through than it is to navigate the whole way around. So anyway, I like these examples of people thinking about other ways that we can try to use the EBUS scope to get to where we need to get to. And so obviously there's also been sampling of adrenal glands and adrenal lesions with this scope as well. Not commonly though. Usually the EUS scope is a better device for that. And then also while we're in there, let's face it, we'll go back to our normal traditional job with EBUS, which is to sample the lymph nodes for carcinomas and staging, is to explore the vessels. And in fact, frequently, of course, the vessels are part of your landmarks of being able to ensure that you are anatomically in, 4L, that you are in 4R, et cetera, and then seeing both the pulmonary arteries when you're in 11RS, et cetera. So along those lines, you should be exploring the vessels because you will find pulmonary emboli. And though the patient may have had a CT scan looking for pulmonary emboli, it may not be present. on that CT, or that CT was a couple of days ago, and now you're bronching this person. And they're not, as we all know, they may not always be symptomatic. The keyword is symptomatic yet. So a nice little just, series by Allmiller of 32 patients with an angio CT that was done. It documented 101 PEs across, meaning there was one on the left, one on the right, and so forth. And then they explored whether or not you could detect these with EBUS. And 96% of the emboli seen on CT were evaluated by EBUS. So here the idea was to go kind of prove it, which obviously, if I see a PE on CT, I believe it. So, the idea though is that this ultrasound technique can clearly find emboli. So we survey the vessels while we're in there, because it doesn't take long, and obviously it would change management in regards to anticoagulation. And the 4 emboli that were not detected, 1 in the middle lobe and 3 in the left upper artery. So 2 areas that would be obviously challenging to get to, especially if they're a little more distal. And it basically found at least 1 embolus in every patient, which I think is the other key finding. If you find, because you really only need to find 1 in regard. So here you can hear me talking. Yeah. So with that, I hope I didn't go too long. If not, feel free to clip it and edit it, audio visual guys. But this is my contact information. This is my institution right here. This is our main hospital. These are our other medical centers, and then these used to be the hospital. These are all research labs now and so forth. And then this is the main University of Chicago campus, etc. But there's my email. There's my cell phone. I am on Telegram, Instagram, WhatsApp, and LinkedIn. Feel free to reach out and connect with me.
Thank you, Dr. Kyle, for your excellent talk on utility of endobronchial ultrasound beyond staging. And it's been a wonderful session today where we had talks by 3 eminent international faculties on all the latest updates and advancements in the field of linear EBUS. We hope that this webinar is useful to you in your day-to-day clinical practice, as well as in advancing the science of endobronchial ultrasound. So with this, we close this session, and we hope to meet you soon again for another wonderful webinar. If you have any queries or any questions, you can feel free to drop the message, and we would like to respond to your questions as well. Thank you.